Good evening to everyone and welcome to today's wonderful session. ENT, ear, nose, throat. There are going to be about 10 to 15 questions in tomorrow's NEET PG. Today and tomorrow we'll try to review around 90 questions based on AIMS NEET PG All India in the last 5 years, 2015 to 20. And that will precipitate a lot of key topics which are frequently asked in this easy to conquer subject of ENT. So thank you all for the late evening joining Dr. Murali Bharadwaz. So saccule of the inner ear, from where does it develop? Typically, it is the pars inferior from which saccule of the inner ear develops. You should remember, semicircular ducts and utricle, they develop from pars superior. Saccule and cochlea, they develop from pars inferior. Embryology of the inner ear is the fascinating topic for the examiner. So if you look at the development of the inner ear, it begins third week of fetal life. It completes by 16th week. The membranous and bony labyrinth, they develop from otic capsule. Whereas the ectoderm in the hindbrain, typically it forms the auditory placode, and that become auditory vesicle, and that become the endolymphatic duct, and the endolymphatic sac is what you should remember. So we have one vestibular apparatus for the balance and equilibrium, and a cochlea for hearing is what you need to remember. Tensor tympani. Tensor tympani. So where is it attached? So you should remember, tensor tympani is attached to the malleus. To the malleus is what you should remember. So tensor tympani attaches to the neck of the malleus. It tenses the tympanic membrane. It is derived from the first branchial arch, and it is supplied by the branch of the mandibular nerve, which is the branch of the trigeminal, is what you need to remember. Cough reflex on stimulation of extral-acoustic meatus, extral-acoustic canal. How is it mediated? It is the auricular branch of the vagus nerve, which is responsible for mediating the cough reflex. Whenever you stimulate the external acoustic canal is what you need to remember. So if you go back to the vagus nerve, it has a special visceral efferent, which is nucleus ambiguous, is the nucleus in the medulla, and all the constrictor muscles of the pharynx, intrinsic muscle of the larynx, muscles of the palate except tensor veli palatini, and the striated muscle in the superior 2/3 of the esophagus. It is all the motor nucleus is nucleus ambiguous, which comes from special visceral efferent. General visceral efferent are the dorsal vagus nuclei in the medulla. They supply the smooth muscle of the trachea, bronchi, digestive tract, and cardiac muscle. Then general visceral afferent, special visceral afferent, it is the solitary nucleus in the lower medulla. So general visceral afferent, it brings the visceral sensation from the base of the tongue, pharynx, larynx, trachea, bronchi, etc., etc. And also from the heart, lungs, heart, bronchi, esophagus, stomach, and intestine. And special visceral afferent brings taste from the epiglottis and palate. And general somatic afferent, it is the sensory nucleus of the trigeminal. It is in the pons at the level of the C2. The sensation from the auricle, external acoustic meatus, dura mater of the posterior cranial fossa. It is all general sensory somatic afferent. Once more, it is the vagus nerve is what you need to remember. In tonsillitis, it is very painful. Who is mediating that pain? It is the glossopharyngeal nerve. What is the nerve supply of pinna? Is the favorite question of the NEET PG 2018. Facial nerve, vagus nerve, great occipital nerve is not. Great occipital nerve is not involved. Auriculotemporal, vagus, and facial. So, there is a great thing about the supply of the pinna, but it is not great occipital, it is a great auricular nerve. Great auricular nerve supplies most of the medial surface of the pinna and the posterior part of the lateral surface of the pinna. Lesser occipital upper part of the medial side of the pinna, and auriculotemporal supplies tragus, the crust of the helix and adjacent part of the helix. So you should be very sure what is auriculotemporal, vagus, great auricular, what are their territories. You have to be very, very sure about. So great auricular nerve is C2, C3 from the cervical plexus. Auriculotemporal is the division of the fifth cranial nerve, and the cranial nerve 7 and 10 typically supply this area. And this is once more the territory of the great auricular nerve. This is the lesser occipital nerve. So examiner can ask in tomorrow's NEET PG the same question in different formats. एक पिक्चोरियल इमेज बेस्ड देकर पूछेगा एग्जामिनर इस एरिया को कौन सा नर्व सप्लाई कर रहे हैं, इसलिए इसको आप गर्मा गर्म बट्टी मारना पड़ेगा. Now, earliest age where the BERA, the brainstem evoked response audiometry, it can be done at birth. It is a objective test, not a subjective test. Negative rini with 256 Hz tunic fork indicate how much of air-bone gap. Another very standard question. Rini's test, Weber's test, you have to be 100% sure on all the tuning fork tests. Every NEET PG exam may one question definitely puchega examiner is what you should remember. Serous Otitis media. Which type of tympanogram? All types of tympanogram. Favorite question of the examiner. Type B. So, doctor, a normal pressure and compliance. Then you will get this kind of A type of tympanogram. AS, normal pressure, low compliance, typically in a stiff middle ear system. 80 to 75% have a effusion with AS. B, pressure is less than 100 millimeters of water. There is a low compliance, typically effusion is possible. And C, negative pressure, negative middle ear pressure because of the Eustachian tube dysfunction typically lead to development of type C. So doctor, invariably once more tomorrow's entrance में एक image based question आएगा, right? So don't forget and that would be coming from tympanogram. You will be remember Murali Bharadwaz in the exam hall. Okay, so now Delix Hallpike's test is done for semicircular canal. So Dix Hallpike, long sitting, the head is turned 45 degrees and a drop down of the neck about 30 degrees of extension will bring back the vertiginous feeling. So Dix Hallpike's test, you should not forget, for semicircular canal. Malignant otitis externa. What is except about it? Though the word says malignant, it is not malignant. It occurs in diabetics. You use gallium scan to monitor it, and surgical debridement is rarely needed. They're all true statements. So, if you want to diagnose malignant otitis, which is a necrotizing otitis. So, what are the major and minor criteria is the question of the examiner. So, pain, exudate, edema, granulations, microabscess, positive technetium bone scan, failure of local treatment after more than 1 week. Minor criteria: pseudomonas in culture, diabetes, old age, cranial nerve involvement, positive radiograph, and any debilitating condition which is predisposing factor. They are the criteria for malignant otitis. Don't forget, examiner जरा ये criteria के मामले में आपको पीछे पड़ेगा. So obligatory criteria, supplementary criteria for the necrotizing external otitis, which is the malignant otitis. So this is how the typical gross appearance looks like. A 55-year-old uncontrolled diabetic with fever, with severe pain, active pus discharge since 3 days. There's a granulation tissue. Khatam, you know what are the major minor criteria now? Oh, he puchega examiner. So what is your answer, doctor? Malignant necrotizing form of otitis externa is what you need to remember. Now, identify this condition that you are seeing in this image. This is keratosis obturans. So what is keratosis obturans, doctor? Very simple. Whenever keratin is desquamating, it is the accumulation of this desquamating keratin in the external auditory meatus is called keratosis obturans, is what you need to remember. So the keratin squames, they are being shed from the complete circumference of the deep ear canal and they form a layer. And all the geometrically patterned keratin plug within the lumen of that expanded ear canal, typically, it can be silent type, no predisposing acute infections, abnormal separation of keratin, and it persists even after removal. Inflammatory type, because of the acute inflammation due to increased epithelial turnover and the alteration in the epithelial migration, they are all responsible. Then primary cholesteatoma of external auditory meatus. It is due to the irregularity and erosion of the bony wall. It can be post-traumatic, post-surgical, and the squamous epithelium is invading into the bone, which is responsible for it. And always take a histopathology to rule out carcinoma. So this is a classical example with all those squames, neglected keratosis obturans, and this is the cholesteatoma of the external ear canal, is what you need to remember. So how do they present? Severe ear pain, mild to moderate conductive deafness, Often there is an associated bronchiectasis, sinusitis, primary ciliary dyskinesia, rarely otorrhea. And the canal, when you clinically examine, is occluded by a plug of the white keratin debris, is what you will be able to see. And if you do the CT, the widening of the external canal with bony erosion is a CT hallmark. And how do you treat? Treat the cause. If it is an impacted wax, syringing. Inflammatory type, treat the infection. If it is a foreign body, treat by instrumentation. Now, Grady-Negos syndrome. What are the characteristic clinical triad, doctor? Diplopia, retrobal orbital pain, and a persistent tear discharge. So whenever there is mastoiditis, acute petrositis in the petrous tip, acute petrositis leads to facial weakness, pain, and hearing difficulties. So Giuseppe Grady-Nego, Italian, found that there is a ipsilateral hearing loss due to eighth nerve involvement, ipsilateral facial pain in distribution of cranial nerve 5, ipsilateral facial paralysis because the seventh nerve involvement. That characterizes the Grady-Negos syndrome, is what you need to remember. Citally abscess. Typically it is formed over the occipital bone, the Citally abscess. So bejeweled means neck swelling on sternocleidomastoid muscle. Citally is neck swelling on the posterior belly of the digastric muscle. Posterior belly of the digastric muscle is called Citally, is what you should remember. Tobey-Ayer's test. Where is it done, doctor? Whenever lateral sinus thrombosis, sigmoid sinus thrombosis is there. What is Tobey-Ayer? If you compress the internal jugular vein, there's a rapid rise in CS of pressure, followed by a rapid fall if you release the compression. Provided there is a continuous transmission of the pain. But in lateral sinus thrombosis, it can't be transmitted. The pain on the internal jugular vein cannot be transmitted. And that's the reason there is no such rise of the pressure on the side where the thrombosis is there. Kraubek's test. If you pressure on the internal jugular vein on normal side, there's an engorgement of the retinal veins, papilledema, which is seen on fundoscopy because of the lateral sinus thrombosis on the opposite side. So the Tobey-Ayer test, Quickensted's test, is what you should understand. So normally if you compress on the internal jugular vein, there is a rise in the pressure, which is normal. But if it is not happening, then think of lateral sinus thrombosis is what you need to remember. A 8-year-old child has history of adenoidectomy done 1 year back. He now complains of effusion. So what is the likely possibility? Rarely, recurrence may be underlying cause. So the adenoid regrowth and recurrence of symptoms, it is a bit controversial, but that could be one of the possibilities. Serous otitis media. Typically, there is a effusion of the middle ear due to the respiratory tract infection. It is very common cause of the childhood hearing loss, and there's a loss of light reflex. There are two. Tubercular otitis media. What is a characteristic finding? So tubercular otitis media, 4 or 5 points you should remember. Tympanic membrane with multiple perforations, classical of TB. ATT is the treatment of choice. Pale granulation tissue is seen, but it is a painless condition is what you need to remember. So preauricular adenitis, metastatic spread can also be responsible, and painless otorrhea, and it can be blood-stained otorrhea. So facial nerve paralysis, without that there is no question paper, because facial nerve is common in general medicine, anatomy, ENT, surgery, so many places. Everything, anything about facial nerve, trigeminal nerve. Trigeminal is dentist nerve. Trigeminal nerve, vagus nerve, glossopharyngeal nerve. Definitely one question is going to come, you are going to remember me. So we discussed all this in the onlinemmbbs.com video library. Just subscribe and enjoy doing the revision. A lesion at which point along the course of the facial nerve lead to loss of lacrimation and taste. So this is one table you should remember, doctor. This one important imagery should go and sit in your mind. So from the facial nerve comes the nerve of pterygoid canal. So you should remember the facial nerve gives rise to the greater petersal nerve, which passes through the pterygoid canal to become the nerve of pterygoid canal. It reaches pterygopalatine ganglia and ultimately supplies the lacrimal gland, which give you tears. So that is the reason loss of lacrimation typically occur if there is any lesion proximal to the geniculate ganglion. That is what you need to absolutely remember. So after leaving geniculate ganglion, even the taste fibers separate from it. There is a chorda tympani nerve also separates out of it. So this is one table, doctor. एक फुटवा ले लो दिल के अंदर रखो कल के एग्जाम के लिए. बराबर? Now, how do you do the testing of facial nerve injury? Schremer's test, put and see how the tears. Taste test, salivary flow test, not the Bing test. Achha, what is Bing test? It is done for bone conduction. It examines the effect of the occlusion of the ear canal on hearing. So, conduction hearing loss patients, they will appreciate no change. That is called Bing negative. Whereas normal people and sensorineural hearing loss, they hear louder when canal is occluded and softer when the canal is open, which is called Bing positive is what you need to remember. So basically you will take one vibrating tuning fork and put it on the mastoid, and examiner will alternatively close and open the ear canal by pressing the tragus inward. So if it is a conduction hearing loss people, they can't be able to appreciate any change of the tuning fork frequency placed on the mastoid. Bing test. Schwabach's test. It is no longer used. It compares patients' hearing sensitivity with that of the examiner's hearing sensitivity. So that is called Schwabach's test, which is not a surgical landmark for the facial nerve during parotid surgery. During parotid surgery, tragus, posterior belly of digastric, and retrograde dissection from the terminal branches, they all act like a surgical landmark of the facial nerve. Meniere's disease, what is the triad, doctor? DVT. D for deafness, V for vertigo, T for tinnitus. Electrocochleography, where do you use? Typically in Meniere's disease. So doctor, इतना frequently नीट पीजी 2020 में भी आया, 2020 में 2 क्वेश्चंस आया, मतलब मीनियर्स डिजीज एग्जामिनर के क्वेश्चन बैंक में बैठा हुआ है. So let us become the champions in this important topic. So doctor, this is the Reisner's membrane, and any hydrops of endolymphatic sac is mania. So why should there be any hydrops? Why there should be fluid collection in the endolymphatic sac? Either defective absorption, any allergy, autoimmunity, viral infection like herpes, or any stress, sodium water retention, or hypothyroidism. Any of them can be responsible. So patients will have episodic vertigo, fluctuating hearing loss, tinnitus, oral fullness. They're all the features that you see in case of menias. Now, doctor, what is the age group for mania? Mania happens 35 to 60. Males more, unilateral, vertigo, which is episodic, sudden, 20 minutes to 20 hours, vagal symptoms, Tullio's phenomena. What is Tullio's phenomena? And Tumarkin crisis. And hearing loss. What type of hearing loss? Fluctuating, sensory neural hearing loss, diploiactusis with recruitment. Now, Tullio's phenomena. It is a subjective imbalance and nystagmus which is observed in response to loud sound. Any low frequency noise exposure will lead to subjective imbalance and nystagmus. So other than menias, where else it is seen? Superior canal dehiscence, perilymphatic fistulas, post-fenestration surgery, etc., etc. If you look at the tinnitus in menias, it is low pitch, roaring, and near the attack there is a change in the pitch and loudness. There is an episodic oral fullness. And what is very important, if you do otoscopy, absolutely normal. Nystagmus need to be episodic. And the fast component of the nystagmus is along the unaffected ear. And the tuning fork test will show sensory neural type of hearing loss. Recruitment test is positive. And speech intelligence score more than 70%. Tone decay test less than 20 decibels. Electrocochleography, SP by AP ratio. This is SP, this is AP. SP, AP, the electrical signal. It is more than 30%. Caloric test will show reduced response. Glycerol test, typically, these are all the investigations. Then electronystagmography, BERA, CT scan, MRI. MRI mainly to rule out any cerebellopontine tumor. CT scan, normal aperture 6 mm, but in menias it becomes 2 mm. That's how you will identify. So typically this is the posterior semicircular canal. This is a vestibule, and there is a bony destructive lesion along the posterior part of the petrous apex in the region of the vestibular aqueduct. This is the place where CT will help you. So what are the various variants of this? It can only be cochlear hydrops, vestibular hydrops, Tumarkin's otolithic crisis, and Lermoyes syndrome. At least you should know what are these in Meniere's disease. Otolithic crisis, also called Tumarkin's attacks. Typically, it occurs without any warning. vertigo, nausea, sweating, disequilibrium, numbness, paralysis, the feeling of being pushed to ground, but there is no loss of consciousness. And it is because of a sudden increase in the labyrinthine pressure leading to a sudden onset of vertigo is called the Tumarkin's otolytic crisis in case of the Meniere's disease is what you need to remember. Lermoyes syndrome क्या होता है? It is a variant of Meniere's. Sudden sensory neural hearing loss, and it improves during or immediately after the attack of vertigo. That is called Lermoyes syndrome. Right, doctor? So, can Meniere's endolymphatic hydrops, can it be secondary to something? Yes, sir. Trauma, viral, syphilis, Cogan syndrome, where there is an autoimmunity with eye symptoms along with vestibular cochlear symptoms. Any otosclerosis, staphylectomy, autoimmunity, any tumor like acoustic neuroma, anything can lead to a secondary Meniere's is what you need to emphatically remember. So what is the closest to differential diagnosis to the Meniere's syndrome, doctor, where all these symptoms appear? Vertiginous migraine. Typically in vertiginous migraine, which is the close differential of Meniere, there is an aura, headache, relieved by sleep and precipitated by the stimulus. Now, how do you treat? Prevent. Avoid coffee, tea, alcohol, excess water, no added salt diet, stop smoking, avoid stress. Already vertigo is a big stress patients will have. You say avoid stress, who can avoid? Then vestibular sedatives, very commonly everybody vertigo means they will start a vestibular sedative. Diazepam, metropin, carbogen, histamine, etc., etc. Then even Lasix 40 milligram alternate day is being given. Then chemical labyrinthectomy is one of the choices. So how do you do? Chemical labyrinthectomy, amikacin, kanamycin, dihydrostreptomycin are all cochleotoxic. Gentamicin, streptomycin in low doses can be vestibulotoxic. So they destroy the dark cells which are responsible for producing the endolymph. So intratympanically, gentamicin is being injected, and that is how you do the chemical vestibulectomy. Paracusis wilsii. Typically, otosclerosis patients, you see paracusis wilsii. Pink reflex through an intact tympanic membrane. Whenever there is any active otosclerosis, what is that called? Schwartz sign. What is the earliest reflex lost in acoustic neuroma? Acoustic neuroma, cerebellopontine tumor compresses the fifth cranial nerve, which is in close proximity to it. That's the reason there is a loss of corneal reflex, which is earliest. With regard to the vestibular schwannomas, you see how important is the topic of acoustic neuroma. NEET PG 2020 में 2 क्वेश्चंस आए एक ही टॉपिक से, इतना खास बूस है. So you should remember, commonly it is from the superior vestibular nerve. This is also a very, very important MCQ. It leads to cochlear type of hearing loss. Hitzel-Berger sign is because of the involvement of 7th nerve. These are the important things about vestibular schwannoma. By Hitzel-Berger sign क्या होता है? Whenever 7th nerve is involved, there is a hypoesthesia in the posterior meatal wall, which is called Hitzel-Berger sign, is what you need to remember. So what is this maneuver, doctor? दाएं हाथ मुड़ना, बाएं हाथ मुड़ना, मुड़ मुड़ के. What is this maneuver called? A please maneuver. So Dix, Hallpike and a please maneuver. You should not forget. Obliteration of the nasal cavities. In atrophic rhinitis it is used. Now comes a little bit interesting point. Occipito-mental view with a open mouth को क्या बोलते हैं doctor? Pyres view. Pyres view. So let us quickly run through these views. Every time examiner keep asking the same question. This is the PA view. Sagittal suture, frontal bone, then frontal suture, all the structures are seen. The entire skull should be on the film and the petrous ridges will be superimposed with the orbits. Petrous ridges will be superimposing on the orbits. This is called calval sinus projection. So, to clear the petrous ridges and you want a bony orbit to be better seen, you use calval sinus projection. So, frontal sinus and ethmoidal sinus, they can be seen better with calval sinus projection. Chamberlain-Townes projection. The tube is angled to throw the anterior part of the skull away from the occipital region. Occipital is the focus. This is the lateral view where you can see the pituitary fossa, sella turcica, erosion of it, everything. So the skull lateral film, the facial bones and the sinuses, they all appear dark. Now this is the base of the skull view, basically. This is also the base of the skull view. And this is the base of the posterior part of the skull to evaluate the upper cervical spine. This is called Schuller's projection. So, Schuller's projection mainly is to look for the temporomandibular junction and the pathology of the temporomandibular junction is what you need to remember. So, temporomandibular junction, mastoid 8 cells, inner ear, etc. This is called Waters view. You can see the frontal sinus, then the zygomatic bone, the petrous ridge, and maxillary sinus, the carotid process, etc., etc. So this is called Waters projection sinus. And any injury involving maxilline orbits can be seen with the Waters projection, sinus projection. This is called lateral sinus projection to see the fluid levels in all the sinuses. Now, Agar Nasi, what is it? It is the elevation in the middle turbinate ko bolte hain Agar Nasi. Woodruff's plexus is the favorite question. Posterior inferior part of the nose mein Woodruff hota hai. So it is the posterior end of the middle turbinate, you have the Woodruff. Sphenopalatine artery anastomosis with the posterior pharyngeal artery, and the most common site of the posterior epistaxis is the Woodruff, is what you should remember. Then where is little? Little is the antero-inferior part of the nasal septum. And it has the caudal part of the nasal septum has a very rich submucosal arterial network, Kieselbach's plexus. And what constitutes this Kieselbach? Anteric-pointal, sphenopalatine, superior-labial, greater palatine. And each of them are the branches of the which vessels. That is the favorite area of the examiner. So, one question on epistaxis, without that there is no question paper. If there is an continuing epistaxis, even if you ligate the external carotid, then it should come from a branch of internal carotid. So which one is that? Anterior ethmoidal artery. One of the branches of the internal carotid is ophthalmic artery. Ophthalmic artery का branches होता है supraorbital, posterior ethmoidal, anterior ethmoidal, medial palpebral, etc., etc. Killian's polyp is other name for the anthracoinal polyp. Once more, anthracoinal versus ethmoidal polyp के बीच में क्या फर्क है? Which will recur? What is the age group? How do you treat? Everything you should be sure. What is the most common finding causing orbital cellulitis? Orbital cellulitis. Very good. We have Gauri Shankar. Thank you, Gauri, for joining. Chandan, super. Very good, doctor. So, most common fungus causing orbital cellulitis. Always mucormycosis. Anybody coming with diabetic ketoacidosis with a black mass on the nose. High mortality. You need to be very careful of mucormycosis. What is the lower border of the hypopharynx? It is the lower border of the cricoid cartilage which forms the lower border of the hypopharynx. Wonderful, Gauri. Very good to know. Gauri is MD General Medicine. Excellent. So, hypopharynx is the lowest part of the pharynx, lies behind and partly on the larynx. Its upper limit is the plane passing from the body of the hyoid to posterior pharyngeal wall. And lower limit is lower border of the cricoid. And where does hypopharynx lie? Hypopharynx का दूसरा नाम है laryngopharynx. Third, fourth, fifth, sixth cervical vertebrae. And this laryngopharynx is divided into piriform fossa, postcricoid area, and posterior pharyngeal wall is what you need to remember. Very good, Gauri. I am so proud to know that you are an MD General Medicine. It is our blood group and it is our heartbeat, General Medicine. Once General Medicine, till the last breath of your life, you can keep treating patients, right? So that's the thing. So Gauri says, still listening to your class, sir. I followed your classes during my preparation and it helped me a lot. Thank you very much for the kind words, Gauri. Wonderful students like you make me always feel proud. Though it is your effort with which you got it, but we always take a claim that we added a little bit of petrol and ignition, right? That's the only thing that we will be able to do. And of course, it is that God-given opportunity, at least 1 hour, we can teachers like us who are, for whom to teach is a religion. What you repeatedly do is called religion, one's religion. Namaz 5 बार पढ़े तो मुसलमान बन जाते. Sunday जाके बाइबल Christian बन जाते. Similarly, every day 1 hour spending and teaching is like a religion for teachers like us. And we should be thankful even at midnight, 12 o'clock. You all guys are able to join the session to keep the teacher also glowing and blowing and flowing in all that energy levels. Now, doctor, with regard to the adenoid, adenoid is also called nasopharyngeal tonsil. It atrophies at puberty. And any adenoid atrophy can lead to disuse atrophy of, hypertrophy can lead to disuse atrophy of alanine. But adenoid is not capsulated. Adenoid is a pink globular mass vertical ridges, no crypts, lined by ciliated columnar epithelium, and there is no capsule for adenoid. This is one important point the examiner want to test you. Parapharyngeal space, parapharyngeal abscess. Everything you should know. Typically, it is the styloid process that divides it into anterior and posterior, not mastoid. It is also called pharyngomaxillary space infection. Tonsil is pushed medially. It occurs after a tooth extraction. So parapharyngeal space is pyramidal in shape. Medially buccopharyngeal fascia, posteriorly prevertebral fascia, laterally medial pterygoid, and it is divided into two compartments, anterior and posterior, by styloid process, pre-styloid, post-styloid. That is what you need to remember. A young boy, dysphagia, soft husky voice, drooling of saliva, and on examination what you are able to see, doctor, it is the quinsy, the peritonsillar abscess. Once more, tonsils is a favorite area of examiner. Very good, Chandan, I am very proud of you. Good, keep answering, doctor, when the discussion is going on. No, some good points that come to your mind. 1-2 points, post karo. What is the most common site for branchial cyst? It is the anterior border of the sternocleidomastoid. Most commonly, it is diagnosed in second and third decade, and after upper respiratory tract infection, it will enlarge. And branchial cyst is a second branchial anomaly, commonly along the anterior border of the sternocleidomastoid. It can lead to pressure symptoms, is what you need to remember. So what is this sign, doctor? You are able to see the steeple of the church. So that is typically seen through the laryngotracheal bronchitis is what you need to remember. In recurrent laryngeal nerve palsy, which muscle leads to vocal cord to go into median position? It is the cricothyroid. So you can see this is the cricoid cartilage, arytenoid cartilage. The lengthening and tensing of the vocal cord because of the cricothyroid. It is this cricothyroid that keeps the vocal cord in median position whenever recurrent laryngeal nerve palsy is there, is what you need to remember. So, all the vocal cords, what is their vocal cord vessels, what is their nerve supply, and the types of vocal cord paralysis. Oh my God, favorite topic. So, Dr. Chandrasekhar is a luminary teacher in ENT we have. So, Dr. Chandrasekhar has explained everything very nicely, and it is all those videos are made available in the online mbbs.com video library, doctor. Good to see refer ERs and many more. Bilateral recurrent laryngeal nerve. दोनों साइड का recurrent laryngeal nerve डूब गया बोले तो कौन डुबाया? Post thyroid surgery, it is one of the important etiological factor. Now comes the favorite topic of the examiner. Carcinoma larynx. So, a patient with carcinoma larynx involving the left false cord, left arytenoid, left aryepiglottic fold with bilateral mobile true cords. What is the treatment of choice? Beautiful question. Very deep question. हम तो उतना डीप ईएनटी कब पढ़ा, कहाँ पढ़ा? एमबीबीएस में तो खाली भैया टॉन्सिल क्या है, लैरिंक्स क्या है, लैरिंक्स इज डिफरेंट फ्रॉम फैरिंक्स बोल के बोले तो एग्जामिनर बोलेगा क्या बात किया. और लास्टली बिफोर फेलिंग, unless you do a lot of effort, we don't fail in MBBS. लास्टली वो पूछेगा अरे बच्चे को नक को फेल करना छोड़ दो, बोलेगा इंटरनल एग्जामिनर. अच्छा, मैं एक क्वेश्चन पूछ के अगर वो करेक्ट बोले तो मैं पास करूंगा. बेटा टिम्पैनिक मेम्ब्रेन कहाँ रहता? You will tell inner ear में रहता. खत्म. He will feel, please let me fail at least one student and go. So उतना मासूम होता है हम MBBS में. और carcinoma larynx में different types of surgeries and which surgery, which person, which stage, where will you use? Everything is academic masturbation, doctor. Too much. MBBS level में कहाँ होता है? ये सब कौन पढ़ सकता? क्यों याद करना? See, if you ask a simple thing like penicillin, right? After MBBS, even without post-graduation, what you generally practice, if that is the question, that's great. But deepest level of questions, just to filter the competition, is nonsense. But we still need to prepare for all that nonsense to become the toppers in the tomorrow's exam, right? So I'll take a little boring time to discuss few things which are all at your level. MBBS level में ENT MS final year का level का है. So, but still you need to read. So, the decision of managing the laryngeal cancer, like any surgical oncological condition, is it early T stage, intermediate T stage, or advanced? T1 or T2, T3 or T4A, T4B? Glottic, supraglottic or subglottic, they are all the considerations. अच्छा, glottic cancer शुरू करेंगे. अगर glottic cancer है midcord में, anterior commissure में, T1 stage में, what will you do? Transoral laser resection. Laser लगाओ, destroy करो. Transoral laser dissection is the treatment of choice in most of the cases whenever midcord is involved in a case of the glottic cancer in the stage T1. If the transoral laser resection is unsatisfactory, radiotherapy. If neither of them are feasible, then open partial laryngectomy. Similarly, T2 stage में है, midcord में है या anterior commissure is involved. If anterior commissure is involved, OPL is the treatment of choice. Open partial laryngectomy. But if midcord is involved, then typically the transoral laser resection is considered to be the treatment of choice. Then T2 glottic cancer with impaired cord mobility. Cord nahi move ho raha hai. So how do you manage? If it is midcord, then you do open partial laryngectomy. So vertical hemilaryngectomy is the treatment of choice. And T2 stage mein, you don't use total oral laser resection. If surgery is not feasible, then chemoradiation. If anterior commissure is involved, then OPL is the treatment of choice. And either supracricoid partial laryngectomy or frontolateral partial laryngectomy is what you need to do. Then if it is supraglottic T1 or T2, is it marginal zone, infrahyoid or extension to glottis? That's called glottic supraglottis. If glottis supraglottis is involved, then chemoradiation or supracricoid partial laryngectomy. If it is marginal zone, T1, T2 supraglottic area, then the TOLR, transoral laser resection, is considered to be the treatment of choice. But if it is the infrahyoid supraglottic, then patient fit to surgery, then do supraglottic partial laryngectomy. Unfit, then N0 or N1. If it is N0, radiotherapy, N1, chemoradiotherapy. That is the choice. Wow, that's good. Good to see one more gun. Good evening, sir. I got radiology last year. Wonderful, doctor. Thank you so much for all you guys coming and telling every day. I got in general medicine, I got in surgery, I got in radiology. It will make all the students who are currently attending this session really energetic. I want to tell to all the guys in this midnight attending along with Dr. Murali that nothing is impossible. Only you need to have that trust and faith in yourself. First thing. Second, focus. 950 topics, 30,000 MCQs. एक मर्तबा रिविजन करो, topic wise break करके, at least one time. You don't take 300, 400 hours. You still have all the time available for you, right? So now, T1, T2, subglottic cancer. There is no scope for voice conservation. Axial beam radiotherapy is the mainstay of treatment, and if meds are there, then chemoradiation. So I leave the literature for you, doctor. T3 hai to kya karenge, T4 hai to kya karenge. But 1-2 words about vertical partial laryngectomy and horizontal partial laryngectomy. So vertical partial laryngectomy, hemilaryngectomy, frontal laryngectomy, extended hemilaryngectomy, especially if it is involving the arytenoid tumor. So what are the indications? I just leave the literature for you. And what are the limitations of vertical partial laryngectomy and how do you do? Then horizontal partial laryngectomy can be horizontal supraglottic or extended horizontal partial laryngectomy. So what are the indications? When will you do a horizontal supraglottic partial laryngectomy? Then what are the scenarios where surgery is better than radiation or chemoradiation? And what do you do in supraglottic laryngectomy? You divide thyroid cartilage, clear the preepiglottic space, resect the tumor and do the reconstruction. And this is called extended supraglottic laryngectomy. Whenever there is any arytenoid, piriform fossa, vallicula involvement is there. So that is all the story of the various surgical options. So what is the treatment of early stage laryngeal carcinoma, doctor? Radiotherapy, it is highly amenable. After laryngectomy, how is the dynamic esophageal voice is produced? It is from pharynx and esophagus. What is this vocal cord lesion you are able to see, doctor? Laryngeal papillomas. Inspiratory stridor. Typically, whenever the lesion is above the level of the glottis, then at the time of inspiration, gurr, gurr sound aega. Inspiratory stridor. Surgical widening of the external auditory canal ko kya bolte? Myotoplasty. And what are the pathologies where you want to do myotoplasty? Suppurative chronic otitis media, cholesteatomatous chronic otitis media, congenital stenosis or any refractory otitis leading to acquired stenosis. They are all the conditions where myotoplasty is basically done. The last question for today's evening. What are the types of tracheostomy and what are their indications? High tracheostomy is done for carcinoma larynx. High बोल के कब बोलते हैं? First tracheal ring को level में kasak, fasak. The high tracheostomy, why do you avoid? Because post-operatively there can be perichondritis of the cricoid cartilage, subglottic stenosis. So in case of the carcinoma larynx with the stridor, when the total laryngectomy would be done, that is the only indication for high tracheostomy. You'll remember, right? Then mid-tracheostomy, second and third tracheal rings, you need to divide the thyroid isthmus or retract it upwards. Low tracheostomy is at the below the level of the isthmus, where the trachea becomes deep. So that is a point you need to remember. So, doctor, with this, we come to an end of this. आज का हरि कथा कालक्षेप खत्म. So, doctor, every day 1 hour रात हो, दोपहर हो, शाम हो, कभी भी time मिले, I will definitely take opportunity to spend 1 hour with you. That's my promise. Every 2-3 days we finish one subject. Parallelly, make it a point to go back to onlinembbs.com video library and do the revision. Good night and enjoy a great evening. Thank you.